Tuberculosis. Tuberculosis is a bacterial infectious disease caused by Mycobacterium tuberculosis complex, which is of three types mainly: human, bovine, and africana. It's also known tubercle bacilli because the lesion it causes is like a tubercle in the lung or any other organ. Also caused acid fast bacilli because during the test, when we test the sputum, for example, we add acid, and this acid will decolorize the cells, the normal cells in the sputum, giving it white color without any color, any other color. While the TB bacilli, if present, then it will resist the decolorization and shows pink color. Tuberculosis affects all races and ages without exceptions, although it tends to be more in the adolescent and young age, and also in the immune suppressed patients. It affects all organs. The infection occurs almost exclusively through the respiratory system by inhalation of tubercle bacilli. So most of the cases of tuberculosis, whether in the lung or in other organs, there should be a primary focus in the lung in more than 95% of the cases. But sometimes it stays silent, and even though it's transmitted to other organs showing secondary TB. This of course depends on the dose of the microorganism in the droplet, the dose inhaled by the patient, the close contact, the duration of the contact. The longer, the more chance to get the infection. Each smear positive pulmonary TB will transmit infection to 10 to 15% per year. And when we say infection, we mean transmission of the infection of the bacilli to others. It doesn't mean disease, because disease means pathological changes, while here there is an infection but not necessarily a disease, because those who will be infected with TB will wall off the TB bacilli and can remain dormant for years. About only 5 to 10% of the infected individuals will have the chance to develop TB in the future during their lifetime. More than 90% of global TB cases and deaths occur in the developing world, where 75% of cases are in the most economically productive age group, which is 15 to 50 years. An adult with TB loses on average 3 to 4 months of work time, which results in the loss of 20 to 30% of annual household income. At issue here to mention is TB is a disease of low socio-economic status. Usually it affects the low socio-economic. Why? Because of bad housing, bad aeration, overcrowding, less sunlight and less gardens and trees, and less food. And if there is any food, then it will be of less nutritive value. For example, no fruits or no proteins. And all these conditions, in addition to that, poverty will prevent the patient from going to the doctors to seek medical care, to buy medicines, or to make some tests to diagnose his condition. All these factors generally coordinate to make tuberculosis more prevalent among the low socioeconomic status. So when the patient gets ill, any person with TB, then he should take a leave for at least 3 to 4 months for the initial course of treatment, and this is for his sake, to get better and to improve and can go back to work, and for the sake of others, like contacts, his family, or his colleagues at work, so at the whole community, so he will not transmit the disease. So the point here is that this person, as we agreed, is usually, not necessarily, but mostly poor. That's why he lives in poor socioeconomic status and housing condition, and he got TB, and then there should be a 3 to 4 months out of work, and so there will be no income during this time. So this will increase the poverty effect on him and on his family, causing more deterioration in the general condition, which will make a good chance for infection of TB for him and maybe for his family. Nearly 1/3 of the global population, that's to say 2 billion people, is infected with mycobacterial tuberculosis and at risk of developing the disease. And as we say, you remember, infection not necessarily mean disease, but this means that 1/3 of the global population can be infected, exposed to TB and infected, and only 5 to 10% will get the disease. But still, this is a very large, very, very large number. More than 8 million people develop active tuberculosis every year, and about 2 million die. And this is not a joke, because if you remember, in 2020, when there is the pandemic of coronavirus, COVID-19, about 500,000 or less than that died, and it was a great global disaster. While we have each year 2 million people at least die because of TB, and nobody mentioned that in a disastrous way. Iraq is considered to be a middle burden country with TB and occupies rank 108 globally and 7 in Eastern Mediterranean region among countries with TB burden size. According to WHO reports, the estimated incidence of TB in Iraq is 45 per 100,000, while the prevalence is 74 per 100,000, and the mortality is 3 per 100,000. So each year, the estimated total new cases of TB that is added to the prevalence, to the current number, is not less than 15,000 cases, and this is a huge number that brings us to the years of the 60s and 50s, when the disease was highly endemic in Iraq. Transmission of infection. We have many routes of transmission, but the main one is the airborne, because as we said, this is mainly a pulmonary disease. So when patients with pulmonary TB speak, particularly when they cough or sneeze, they produce an aerosol of droplets from the bronchial tree, each of which contains a number of bacilli. The number can be very high when coughing, 3,500, but it is much more when sneezing. It's around 1 million bacilli. When they come into contact with air, they rapidly dry and become very light particles. So when they become very light, they will be suspended in air and stay for longer time. The effect of this process, or this characteristic, appears more obvious in a closed space. Droplets can remain suspended for a long time, and the bacilli remain alive for a long time, especially in the dark, and as we said before, with low aeration. The other route is ingestion, but to a less extent, of course, than the droplet, by contaminated unpasteurized milk through the infection with Mycobacterium bovis. Rare routes of transmission: cutaneous, transplacental, and transsexual. Incubation period is 3 to 8 weeks in primary TB and may reach up to many years in post-primary or extrapulmonary TB. This table shows the incubation period of different types of TB. The primary complex in the lung, 3 to 8 weeks usually, but the extrapulmonary may take longer than that, like in the meningeal, miliary, or pleural disease. It may take 3 to 6 months, and in the GI, bone and joint lymph node, it may take up to 3 years, and in the renal, it may take 8 years. Evolution of infection. Primary tuberculosis. When few virulent tubercle bacilli penetrate the pulmonary alveoli of a healthy person, they will be phagocytosed by macrophages, in which they multiply. Then other macrophages and monocytes are attracted and participate in the process of defense against the infection. The resulting infectious focus, made up of inflammatory cells, is referred to as primary focus. The bacilli and the antigens that they liberate are drained by the macrophages through the lymphatic system to the nearest lymph nodes. That's why we usually find lymphadenopathy in tuberculosis, the closed lymph nodes, mostly in the neck and in the axilla. Inside the lymph node, the T lymphocyte will identify the Mycobacterium tuberculosis antigens and will be transformed to a specific lymphocyte and liberate lymphokines and activate more macrophages that inhibit the growth of phagocytosed bacilli. The inflammatory tissue formed in the primary focus is replaced by fibrous scar tissue in which the macrophages containing bacilli are isolated and die. This primary focus is the site of tuberculosis-specific caseating necrosis. So here we have caseation, which will cause necrosis, and this will cause cavitation, and the cavity will be then filled with fibrous tissue. All these complications will destroy the lung tissue, the highly specific lung tissue, which cannot be replaced. Any highly specific tissue like the heart or the brain or the lung or any other tissue cannot be replaced. So if there is a prolonged period of infection with caseation, necrosis, cavitation, and fibrosis, then we will lose part of the function of the lung. The focus usually contains 1,000 to 10,000 bacilli, which gradually lose their viability and multiply more and more slowly. Some bacilli can survive for months or years. These are known as latent bacilli, indicated by development of delayed type hypersensitivity, which can be demonstrated by tuberculin skin test. As soon as an immune response is mounted, most of the foci will spontaneously resolve. However, a number of bacilli may remain latent, may escape either through the lymph node or via the bloodstream and go to other organs, causing extrapulmonary infection. Of course, this depends on the virulence of the bacilli, the amount or dose of the bacilli, and the immune system of the patient. If the immunity is low, then many bacilli will escape and go to other organs. If the immunity is good, then most of the bacilli will be killed. Fortunately, in 80 to 90% of infected individuals, immunity will take the upper hand, ending in spontaneous healing, resolution, fibrosis, and calcification. While in 10 to 20% of the infected individuals, virulence takes the upper hand and may result in active disease. When should TB be suspected? The onset of the disease is often insidious, Symptoms often develop slowly on several weeks. Chest symptoms are often non-specific. Cough is almost always present with sputum production. This is the first and most important sign. Chest pain may happen with or without dyspnea, and less commonly, hemoptysis may occur. And the old fashion of diagnosis was depending on the presence of hemoptysis, and this is not correct because hemoptysis usually occurs in 20% only of the patients or maybe less. So in clinical diagnosis we depend mostly on certain criteria. First, cough and sputum and increasing dyspnea, fever especially at the night or evening, but it is not a high fever, it's about 38 to 39 degrees centigrade, with heavy sweating, loss of appetite, and loss of weight. The patient within few weeks will lose many kilograms of his weight and appears like a very ill person. Suspected TB patient is any patient who has cough more than 3 weeks not responding to ordinary treatment. So this is one of the pathognomonic roles in the diagnosis of TB. When we have patient with cough and sputum for more than 3 weeks and we give antibiotics with no benefit, and in a country like ours which is endemic with TB, then we should think of TB. Here we do not diagnose TB, but we think of TB and we send the patient for acid-fast bacilli. A case of tuberculosis is defined as a patient on whom tuberculosis has been confirmed by bacteriology or diagnosed by a clinician. So, the most important tools in the diagnosis is the bacteriology, which is either acid-fast bacilli, which is successful in more than 80% in most of the centers, including our centers, or culture, which is the confirmation of diagnosis. It will be 100% confirmed, but the problem with the culture is that it takes a long time, about a month, and in this case we cannot wait for this time because we may lose the patient. A patient may go and we'll never see him again. So in these cases the clinical diagnosis is very important. If we suspect clinically tuberculosis, especially if the patient has family history of tuberculosis or previous history of tuberculosis, and the important signs and symptoms like cough, sputum, night fever, night sweating, and loss of appetite and weight, then we will start the treatment waiting for the result. We will do acid-fast bacilli, and we will come to this in a minute, and we can send for culture, but we start the treatment until the results of the culture. What determines case definition? Site of TB. TB affects the lungs in more than 80% of cases, while it affects various organs sometimes in less than 20% of cases, and in this case it's called extrapulmonary TB. Bacteriological diagnosis. To diagnose TB bacteriologically, we need to have either 2 successive specimens of sputum with acid-fast bacilli test give positive results, then we diagnose the patient as having TB. So the first and the most usual diagnosis is done through test acid-fast bacilli, 2 successive positive specimens. In case we have only one positive specimen, then we can use the assistance of a physician. The decision of the physician is very important through the confirmation of the clinical picture. Of course, the culture can confirm the diagnosis, but as we said before, it takes a long time. Chest X-ray is of no great value here. It is important only in supporting the diagnosis when we suspect TB clinically and when we have one specimen positive of sputum, or when we have clear abnormalities in this chest X-ray. Otherwise, it is not diagnostic. Sometimes we may have smear negative pulmonary TB, which means that there is pulmonary TB, but when we send the sputum for fast bacilli, it gives negative results. This can be due to many reasons. Either the patient is not giving real sputum, only saliva, or the dose of the microorganism is small, or the diagnosis sometimes in the lab is not very accurate. In all cases, we can depend here on the general clinical condition of the patient to diagnose TB with the assistance, as we say, and support of chest X-ray, but not only the chest X-ray. Sometimes radiographic abnormalities are very obvious and consistent with active pulmonary TB, so the decision here will be to the physician according to his long experience. He can say or suspect that this is mostly pulmonary TB and start treatment even if the test is negative, because as we said, sometimes there is pulmonary TB but it gives smear negative test in about 20% of the cases. Sometimes you have extrapulmonary TB, that is tuberculosis in other organs other than the lung, like pleura, lymph nodes, abdomen, genitourinary tract, skin, joints, bone, meninges, and the kidney. Diagnosis should be based on one cultured positive specimen or histological or strong clinical evidence consistent with active extrapulmonary disease, followed of course by decision of a clinician to treat with a full course of anti-TB chemotherapy. A patient in whom both pulmonary and extrapulmonary tuberculosis has been diagnosed should classify as pulmonary case. And as you remember, we said earlier that most of the cases are pulmonary and extrapulmonary are relatively rare. And even when there is extrapulmonary, there should be a primary focus in the lung. Case classification. New case: any patient who has never had treatment for tuberculosis or he just started treatment for less than 4 weeks is called new case. What's important here to let you know the policy of follow-up in tuberculosis treatment. We usually give treatment for 6 months, as we'll come to this after a few slides. So after the second month, we do a smear test for fast bacilli and it should be negative. This is the first follow-up smear. The second follow-up smear is after the 5th month of treatment. It should also be negative. And the third final one is after completion treatment after 6th month. So all these tests should be negative to declare the patient cured of TB. So if the patient is declared cured and then he comes again after a while with positive smear, then this is called relapse. If during the treatment the patient remained or become again smear positive, which means that in the first follow-up after the second month he remains positive smear, or in the second follow-up or 5th month he remains smear positive for fast bacilli, then this is treatment failure. If the patient is interrupting the treatment, so of course the smear will be positive, and this is called treatment defaulter. In case that the patient comes every now and then with recurrent smear positive sputum, then this is considered as a chronic case of TB. Well, these points in the diagnosis of pulmonary TB are just to remind you about the summary of the whole policy in the diagnosis. So, first, if the patient has cough for more than 3 weeks, not responding to ordinary treatment, then we should suspect TB. Most important is to look at signs and symptoms, which we already mentioned, most important of which are cough and sputum, and fever, night fever and sweating, loss of appetite and weight, with sometimes hemoptysis. These are the most important clinical features. In addition, we send the patient for a sputum exam by S5 bacilli, which should be positive. Over 90% of the patients with cavitary pulmonary TB or with extensive abnormal infiltration should be smear positive. Therefore, a patient with cavitations on chest X-ray, PD specimen smear for S5 bacilli negative, then he probably has a disease other than TB. The bacteriological examination here is very important in addition to the clinical exam, but radiological exam is of very limited value, so as the tuberculin test. Certain radiological abnormalities that are consistent with TB: nodules, patchy shadow, cavities, but as we said, we cannot rely on chest X-ray unless there are very obvious abnormalities consistent with the clinical picture of the patient. Here is a chest X-ray. Can you see the cavitation? It is sometimes obvious, but most of the times it's difficult to see. We already mentioned these points, which are very important in the diagnosis of